Okay, we're actually live, Jarlath.
Okay. Hello, everybody. Welcome to the meeting. We're starting with the election of chair, and can I have a nomination for chair? Hello, members. Can you hear me okay?
Okay. Yeah, Winston nominates Cllr HUH.
Okay. And so someone.
I'll second. Yeah, I'll second that.
Okay. And can we have a show of hands on Cllr HUH as chair from the members? Right, that looks fairly unanimous from the members. Cllr HUH, do you want to take over?
Thank you very much, Jarlath. Just before we go through any other matters, can I just take, in terms of vice chair, it's traditional we have two and maintain a gender balance. And so I would like to please nominate Councillor Winston Vaughan and Cllr Salva Macallan. Can I have any person to second those individuals?
I can second that.
And any other nominations for vice chair? Fine, right. So I saw lots of people seconding those people. I have had no other nominations, so I'll take it as Councillor Vaughan and Cllr Salva as the two vice chairs. Thank you very much. Just a few matters of housekeeping. Welcome everyone to INEL JHOSC meeting. The meeting is being live streamed on YouTube. It's being recorded. Sometimes members of the press will be watching. Please can I ask everyone to keep their microphones off unless you are speaking. When you are speaking, obviously put them on. Please can I ask all committee members to please keep their cameras on, and in order to get my attention, either raise your hand, either the electronic hand or your hand, or you can pop a message in the chat, but please only do that to notify you've got a question. Please don't start separate dialogue in the chat. Before we sort of go on with the substantive items, apologies for absence. I don't think I've been notified of any, but if there are, please say now. I can't see any. Can I take this opportunity to thank Councillor Vaughan and Roger for their sterling work over the last couple of years in terms of chairing the committee. Thank you very much for your 2-year stint. Can I welcome Councillors Papo and because it's your first meeting. Welcome to the committee. Can I congratulate Dame Alwen Williams on her damehood? Congratulations. Can I thank very much Jane Milligan for her time in leading us over the last few years, and wish you all the best in your job as a new Chief Executive in Devon. Can I also thank David Mayer and congratulating him on his appointment as Deputy Chief Executive in Northampton. And perhaps most of all, can I just take the opportunity on behalf of all of us to say thank you to all the NHS staff across East London for this tremendous work that you've been doing over the last few months. We're indebted to you in so many ways. So thank you, and thank you for the leaders for keeping the morale with your staff as you have done. We've noticed that on social media and other things, what you've been doing. So thank you very much. I haven't been notified of any declarations of interest, and so with that, I will go into the first item, which is item 4, first substantive item, which is COVID and the impacts on secondary care. It's been an incredibly challenging time. We've got Alwen Williams to speak from a Barts perspective as to how it's been. As we understand from the media, we're coming out of possibly the worst stages of it yet, but the hospitals still remain very full. Can you give us a 5 to 10 minute update about how it's been, so what the challenges have been, and possibly what the future holds, the short-term future, and particularly in terms of looking after the staff, who must be incredibly exhausted after this period. So, Alwen, over to you. Thank you.
Ben, thank you, and thank you for your kind message as well. That's most appreciated. Thank you. So I just thought I would give you an overview, and obviously I'm conscious you'll want to ask me questions. So I suppose just to say, I think we, since we last met, I think when we did meet, I think we were describing a expectation that clearly there'd be some resurgence of COVID, and at that time the resurgence was fairly was rising, but very, very slowly and incrementally, which is, I think, probably all what we expected to happen at that point, together with winter pressures. But clearly, the variant virus affected that very significantly. So by the time we got to mid-December, we started to see a very significant escalation in COVID admissions into hospital. And that increase continued throughout December, over the Christmas period and into New Year. And indeed, the peak really of this second surge has been between probably about the 5th and the 19th of January. And maybe just to put numbers into context, and I'm going to use Barts as and obviously as just an example, but at the end of August, we had 8 COVID patients in our hospitals in Barts Health, and on the 14th of January, which was sort of midway through the second peak, we had 835. So it just gives you a scale. And the second peak actually was very significantly higher. I think we've calculated it at nearly double that in terms of patient numbers than the first peak that we saw in March and April. So clearly, the assumptions last time we met in terms of how winter might be taken forward clearly weren't the case as a result of the variant virus and the impact that had in terms of transmission and then clearly resulting in hospital admissions. As you said, that had a very significant impact on the capacity and the way in which we configured our hospitals, and we were having to move very, very quickly to create the capacity so that we could make sure capacity was there to meet patient needs. And again, just in terms of numbers, if we look at critical care at Barts Health over our hospital sites, we ended up with a capacity of something like 225 critical care beds. That was over a doubling of our baseline critical care beds. We reconfigured our hospitals. We were deliberately keeping St Barts Hospital as non-COVID as much as possible. We had some very highly specialised, what we call ECMO services at St Barts, but Barts was really kept as green or COVID-free as possible because we were still taking in heart attacks and doing life-saving cardiac surgery at Barts. So it was at the Royal London, really. The Royal London became a real mainstay, really, during the second surge. We increased critical care beds at the Royal London from 44 to 150. The new critical care unit that was built in March and April came into its own, sadly, but thankfully it was there, and we were able then to provide the capacity needed. And the Royal London effectively became what we called a surge centre for North East London, and took referrals and helped other hospitals, including those in the Barts group, but also the Homerton and BHRT. In terms of non-COVID, so obviously just in terms of COVID, we had a lot of patients in critical care, and we continue to have a lot of patients in critical care currently. So although we're now, as you know, we're over the peak, and the number of admissions is declining by about 3% a day, so more than we thought. Critical care is still only declining at 1% a day. So we foresee that certainly for the next 6 weeks to 8 weeks, we'll certainly continue to have very full critical care units, and that has a very significant impact because, as you know, we're not. Sorry, just lost you then. We're not staffed. Our baseline staffing doesn't accommodate that. So what we've had to do, obviously, is take down routine elective surgery, and staff have transferred and been redeployed into critical care to staff those beds. So we envisage that actually coming down from this second surge will take longer because of that than it did in the second peak. In terms of non-COVID, so just to assure you that for patients needing what we would call urgent and life-saving surgery, that's continued. I've talked about Barts Hospital, the trauma services at the Royal London, stroke services, all of those services have continued to ensure that, but clearly what's impacted yet again, as it did in the first peak, is what we would call routine elective surgery. We've continued as well to make sure our elective patients who are urgent, for example, our cancer patients, again, get treatment and there's no delay. And as in the first peak, London as a whole, and Barts included, and all the hospitals in North East London included, are making use of the independent sector services to ensure that the patients who need cancer treatment get cancer treatment. And indeed, Barts Hospital for patients needing radiotherapy, chemotherapy, oncology, that's again continued to provide services as well. So there's clearly been a very significant impact on elective surgery and we had to cancel our elective surgery from about the 21st of December, and we aren't yet in a position to resume. Now that's for two reasons. Partly, as I say, many of the staff are still deployed into critical care, but importantly, as you've quite rightly pointed out, what we're giving some thought to is how do we make sure those staff are rested and can recover and are effectively, their well-being is such that when we do resume elective care, that staff are able to do that. So that's a very, very critical consideration. I can talk more about that if helpful. Just a few other points. That certainly from a Barts and I know from the Homerton perspective, we've done very well comparatively on nosocomial infections within our hospitals. So we are, both Barts and the Homerton have done very well in terms of infections. And again, I think now that, over the coming weeks, as we plan a resumption of routine elective care, clearly there's a lot of assurance to be given to our patients that it actually, exactly as we had in the summer, that it's safe to come into hospital. We want people to come into hospital. And I'm really, really pleased that our infection control standards have really held up despite the pressures that we've been under. And really the final comment from me really is that this has been, I think a phenomenal team effort. So whether we talk about redeployment of staff into critical care, we've had over 100 consultants doing HCH shifts in critical care to make sure that we were able to support critical care staff. We've had the military we've had some military support and support from the system. So huge team effort all round, and also really to call out the team effort across the system. So working really well with colleagues in primary care, our community and mental health trusts and local authorities to ensure really that we were able to facilitate discharge, avoid admissions where that was possible. Colleagues may want to come in on this, but we had very, very good services in place in terms of virtual ward, pulse oximetry services in the community, a very effective integrated discharge hubs. And that really helped us in the acute sector to make sure that the beds effectively in the hospitals were being used and were there for when patients basically were coming in through the A&E department. And in that period when of the escalating peak from mid-December through to about really to mid-January, we were getting very significant numbers presenting every day. And had we not had that really very strong system working, then our big concern was always every day to make sure we had the capacity in the right place, staffed as well as possible, given the challenges, to provide the best possible care to our patients. So perhaps if I finish there.
No, thank you. That's an incredibly helpful update. Thank you, Alwen. Members, can I open it up for any questions from members? Anyone would like to raise your hands? Councillor Winston Vaughan.
Thank you very much, and thank you very much for that. In terms of staff pressures, have you got enough staff at the moment to carry out the responsibility which is required? And is there any staff that might have retired who has now come back in to assist the staff situation?
So we, yeah, I mean, in a way, the response to what I've just described, which is the second surge, has required us to, as I described, effectively, we've had to cancel routine elective surgery, which we wouldn't wish to do at all, and we then effectively redeployed and consolidated our staffing in our medical wards, our respiratory wards, which are all COVID. And with, you know, at the peak when we had over 800 patients, most of our hospitals really were full of COVID patients. So when we talk about our overall responsibilities, it's very, you know, we regret having to cancel surgery, but the only option was to do that. But to assure you that, as we say, urgent and life-saving surgery has continued. Certainly there have been volunteers, staff who have deferred retirement, some come back from retirement, people have done bank shifts. So effectively, I think all I can describe this is I think we've had a very thoughtful redeployment of staff. We've been very clear in governance terms what that's meant in terms of staffing ratios, skill mix, and as well as that, actually, you know, to be very honest, a real call to arms, really, for people to come in and do shifts. I described the number of consultant staff and others doing that. So I'm confident that we've had, in terms of the staffing levels, that we clearly had to adjust in the way we were delivering critical care and in our general and acute wards, but we still had a very clear safer staffing framework. We moved quite a lot of our medical consultants who would have been doing outpatients, for example, into our ward areas. So we made sure that the wards were well staffed, not just during the day, but at night and at weekends as well. So, you know, I'm confident we had as good staffing levels as we could possibly. But yes, it's true, we brought others in as well to supplement the workforce.
Thank you. I've got Cllr Chowdhury and Cllr Sweden. I'll take them together and then go to answers. So Cllr Chowdhury first, please.
Thank you very much, Chair. First of all, I would like to say a huge thank you to all the member of staff who are working extremely hard. We don't need to be an expert to understand that when there is a huge jump from a small number to a huge number, the pressure, anyone can understand the pressure. So my appreciation for everyone who are working on that field. My question is that obviously the whole situation is new for us all. Now, unless and until someone is desperate of need of going to the emergency or hospital, they won't go, they will stay indoor. And I understand that during COVID, patient get problem with breathing, and when they have a breathing problem, you have to call emergency 999. Was not it possible, I mean, I'm talking about earlier, at the beginning of lockdown probably, when we started to see all these difficulties and pressure on our staff. It was not it possible to provide like oxygen and relevant staff at home so that the hospital would not have been sort of like overcrowded or under that much pressure? Is it making sense what I'm trying to say?
Yeah.
Thank you.
Yeah, it is. Before we come in for answers, can I take Cllr Sweden and also Cllr Salva, please?
Thanks very much. Oh, I'm hearing an echo.
It's been sorted.
Oh, right. Thanks very much, Chair, and thanks, Alwen, for your update. And I'd just like to reiterate gratitude for the way in which all the staff have managed to treat people under almost impossible circumstances. I'm just going to veer perhaps into another item on the agenda, but if you could give a very brief response. I just wondered how things were going in terms of the trust with the staff vaccinations and what the plans are there. And have you got a kind of penciled timetable? I know that we can't schedule the virus's activities. The penciled timetable for the recommencement of elective surgery and outpatients and so on. And are you able to balance that with the need for the hard-pressed staff to have some leave? Because it's been in the national media, the burnout because of people working under almost intolerable conditions has been raised. Thanks a lot.
Thank you, Councillor Sweden. And lastly, Councillor Salva, please.
Mine is really, well, to echo what others have said. Thank you very much for the presentation, especially when you're so busy as well. I would like to just actually follow on from that to say, really, it's the mental health and the exhaustion of staff, how much of that is being factored into the kind of return to business as usual, and whether or not and whether or not there needs to be further consideration around that timetable of return, considering that burnout factor.
Thank you. Okay, Alwen, if you've got those, oxygen support at home, vaccination of hospital staff, and support for staff vis-a-vis elective.
Yeah, okay. So I think what I would say is that the decision as to whether a patient came into hospital or stayed at home with the right community support was a clinical decision, and often that was taken between the general GPs and general practice. Obviously, at times when 111 was called, because patients were asked to call 111, and sometimes at times our acute clinicians were involved in some of those calls, because we had quite an innovative model where we had our A&E doctors on the phone who could do video consultations with the GP with patients in their own home. So just to assure you, those decisions were taken, and clearly where it was feasible for someone to stay at home, that would be the best thing for them, with the right support, and again, community respiratory teams and others supporting them in their own home. I think the issue with COVID at times is patients could deteriorate quite quickly. So I think, again, that clinical assessment was absolutely critical about whether patients really ought to go into hospital, and really to assure you that was kind of the mechanism. But it was always across this, involving acute and primary care 111 services, in terms of the right decision for the patient clinically. In terms of the blueprint for resuming elective surgery, that's exactly what we're working through as we speak. And your point is well made, that we're very, very conscious that the staff that we will be redeployed or deployed back into their original teams in theatres or in cardiac anaesthesia at Barts Hospital, all of those staff who are currently working at the Royal London in critical care. What we're currently mapping is making assumptions. If critical care continues to decline at 1% a day, and what can we factor in terms of rest and recovery and annual leave for staff, then that's starting to give us a picture. We think it's probably going to be something like early March for some, but limited, and then gradually during March and into April we'll start to resume. It's clear it's a very difficult tension to hold, because on the one hand you can see the needs of the staff, on the other hand we can see the needs of our patients that really need to be treated and brought in. The way we're trying to think about this is that if we take, and the judgments we take on this are going to be very key, because if we go too fast, then clearly staff may go off sick, and we do know that staff working in critical care are self-reporting relatively high levels of PTSD, for example, and that's not saying they've got a clinical diagnosis, but what we now do in the next few weeks to give people rest, to give them opportunities for access to psychological support, to go back to their home teams and start to build those working relationships, debriefings, counselling, the health and wellbeing offer in the NHS is now much, much better than it was over 12 months ago. It's got to be like that forever. It's not just a COVID response. And we have now got psychologists within the organisation that are completely focused on staff. We have psychologists working with patients, but we've now got a team of psychologists who are working with staff who team leaders can access and bring into their teams. And we're pulling together as we speak a guide to all our team leaders, doing webinars with our team leaders about what do individual conversation staff need to look like, and how staff can be navigated to more support should that be needed, or if they need time off and annual leave, that absolutely that's scheduled in. And clearly every individual will be different in terms of what's needed. So that's where we are. We're planning the future. We've got some assumptions, but not yet cast in stone. but very, very mindful that we've absolutely got to give our staff rest, recovery, so that people are in the right place psychologically and in terms of their physical health, to be able to not only be at work but be engaged and leading what will be clearly again a challenging further COVID recovery, albeit a different a different one than we've been tackling in the last 6 to 8 weeks.
Thank you. And Alwen, there was just Councillor Sweden slightly trespassed upon the next item, but I suppose bearing in mind it was very hospital specific. How are you doing on vaccination on hospital staff?
Oh, sorry. Yeah, sorry. So we're doing pretty well with staff vaccinations. So our calculations. We've in terms of our own staff, we're now at about 26,000 overall in our hospital hubs. Now that is a mix of our own staff and some patients and partners that have come into those hospital hubs. Working backwards, and then from that, we think about 85% of our staff now have been vaccinated. Where we're really focusing now, though, is on vaccine hesitancy, because the breakdown in terms of BAME and young BAME staff, there's a mirror inevitably with what's going on in the local population. So our focus now is, obviously we're going to have to gear up for the second dose for our staff, but actually now a real focus in terms of a strategy to tackle and address vaccine hesitancy. As you know, Barts Health is also running the mass vaccination centre at Cllr. That I think will extend in terms of capacity as we get into the next round of cohorts. But we've vaccinated about 16,000 people in Cllr as well since that opened in early January.
Thank you. Members, I want to address vaccine hesitancy in the next item, so if we can sort of hold off on questions on that for the next item if we can. Councillor Chowdhury, your electronic hand is still up. Is that from last time, or have you got another question? No. Another. Any other members with questions for Alwen? Councillor Snell.
Since we haven't run out of time on this item, I guess what's interesting me is it looks as if we are now going to be living with COVID in the way we've lived with flu for years to come. And of course, it's going to be treatment is as important as vaccination. We can get revaccinated every year. But can you just give us a snapshot, I don't know, a rough feeling? Because we understand the treatments have got a lot better. And so in terms of the number of people admitted to hospital with a COVID diagnosis, I knew friends who had asthma said if I was admitted, I'd be dead, a year ago. Well, that's clearly never was the truth, but it certainly isn't the truth now. How have the figures improved in terms of the number of people who end up staying alive and don't have to go into intensive care?
Yeah, so I suppose in a sense the correlation really in terms of impact on hospital admissions, and particularly people that when they get COVID will get seriously ill, absolutely matches the success of the vaccination programme, which is why the question about vaccine hesitancy is so important for East London. So there is a correlation, I don't have it in front of me, which is a national one, which shows very, very clearly that correlation between vaccination, particularly related to age groups, the older age groups, people with underlying health conditions, and that correlation in terms of those patients that would had we had a vaccine in, if you like, from the beginning of COVID, who would not have been in hospital and who, many sadly died as a consequences. So that is absolutely the case. What I don't have in front of me is kind of what does that mean? What might that mean in terms of numbers? And, that for us, in East London, you know, we've really got to take seriously this real question of vaccination for all. Otherwise, you know, as we all know, and I know you're going to come on to this, the question is going to be about exacerbating health inequalities, which absolutely we don't know. But yeah, I mean, you know, there is some light at the end of this tunnel, but it does mean that we've really got to be very focused now to ensure that all our population have access to the vaccine and take that up.
Thank you. And then last question, Councillor Chowdhury, have you got a further question?
Thank you. So again, on the vaccination, actually, I understand that many people are not interested in it. Although, I mean, I asked the same question in different place. I did not have a clear answer. So if it was possible to have a specific number or percentage, then some of the representative like myself, we could communicate with the wider community in our local own areas. You don't have to answer it now, but in the future, near future, shortly, it would be appreciated. And also if you have a clear breakdown of different ethnic background, so if we understand that if there is a specific cultural background who are not taking the vaccine, then we will be able to try and get in touch with them.
Thank you,
I think
our
colleagues, I think my colleagues will come on to that in the next item with the data.
Yeah, so we'll direct that on the next item. Well, with that then, and still being a few minutes ahead of time, I'll thank Alwen Williams very much for your time and draw that item to a close. Thank you for your comprehensive update and for all your work. Alwen, please feel free to go in terms of if you need to do so. And we will now move on to item number 5, which is in terms of vaccination. And we've got, I think, Jay Milligan here, we've got Dr. Mark Ricketts and David Mayer, who are going to give us an overview of where we are with the vaccination programme. And also, you can understandably, there's a lot of questions in terms of vaccine hesitancy and different ethnic community groups. So 5 to 10 minutes, please, for presentation, then I'll open up for questions.
Okay, thank you. I'll just cover some headlines and hand over to my colleagues. So in the pack, there is an updated, we are producing some information now on a weekly basis, and of course that pack is not the most up-to-date one, but we are starting to do that. Just to also confirm, the vaccination programme is you know, a very huge and massive programme. It is a national programme, and we're having to work with our national constraints within that, because as a bit like the testing scenario, we're trying to get make the best of it, shall we say. So by Valentine's Day, so by Sunday, we are required to have offered the vaccine to everybody within the cohorts, which is 1 to 4. So that includes people who are all care home residents, all care home staff, our over 80 population, our care home or our health and social care workers, clinically vulnerable patients, and to be fair, that definition has only recently been, I suppose, agreed, and also sort of the 75 to 79-year-olds. So, and I think certainly we have provided or given vaccinations over 220,000 so far across North East London, and we have another 35,000 to do this month or this week. As you can imagine, and I'll come back to the hesitancy, offering and ensuring people take that up is, not necessarily the same thing, but we have put in place a number of different things to ensure that we are providing that offer as widely as possible, again working within sometimes the constraints that is the national programme. So for example, letters nationally generated, we recognise is only going to really get the certain people in. So we have been utilising all of our different routes of communicating, reaching out to our communities and people who sit within those cohorts, including staff. At where we are currently is that we have, in terms of care home residents, I think we've done well. We've actually are over 80% in that. As Alwen said, in terms of staff, I think certainly trusts are making very good inroads, but we are struggling to get our care home staff above the 40%, and that is I think not some combination of hesitancy, but there's a bit of people want to wait and see almost. I think certainly in our over 80s, again, we are pushing into the sort of over 75s, but within that, across certainly the boroughs of City and Hackney, Newham, Tower Hamlets and Waltham Forest, there is a range, and I'll come back to that in a minute, and I'll ask Mark to pick that up. We really do recognise, though, that there is not one size fits all in how we ensure people have access to the vaccinations, and certainly we have our primary care hubs, also our GP practices, and now since the middle of January are providing housebound and a roving model, so reaching out, because essentially some people really who've been asked not to leave their homes, and suddenly we're asking them to come to the practice or to a vaccination centre. Doesn't work, does it? But we're utilising that as an approach. As we said, we've got the Cllr Vaccination Centre, which I think really will come into its own as we get into further, the larger cohorts, but has already, as Alwen has said, been vaccinating. Westfield is also another area which is part of our sort of mass site, and through the hospital hubs within each hospital too. I think certainly we have started to we've been working very closely with our local authority colleagues and our voluntary sector organisations to really help ensure that we're getting the messages out, and we're using every possible route to invite people for vaccination. And as I say, we're also not just done the first dose, but we are doing the second dose too. We're trying to look at different models, so whether that's pop-up clinics. So this weekend, last weekend, we had that at the East London Mosque with over 100 to 150 people vaccinated through that. But actually also reaching out using all of our social media and webinars and online listening events for different communities, again understanding people's questions and answering those. So City and Hackney are holding a dedicated evening event for the Haredi Jewish community, also looking at providing information in all different languages and using that again through people who are trusted within the community, not just medics, but actually people who are sort of COVID survivors, but also people who are, as I say, working with our communities, and using again some of the social prescribing routes as well as our community champions to help. And local authority colleagues again utilising their call centres to also help us to reach out and essentially try not to over sort of call people, but actually just use different approaches. I think certainly we have got our so there is the national data collection approach, which is clunky, so we're starting to utilise more our local GP and local data, so we can drill down and understand more about our the ethnic our community uptake, and really try to understand not just at a borough level, but actually at a primary care network level, what some of those characteristics are, and we know a lot of that already, and then matching almost, as I say, the approach. We've got an overarching group, vaccination qualities group, which is linking in with local borough-based ones as well, not because we want to centralise anything, but also to ensure that we are sharing good ideas and good practice, and because each patch does have has a different approach. So we've definitely got more to do. We recognise that as we go into the next lot of cohorts, so cohort 5 and 6 and beyond, we need to continue obviously to make sure we're reaching out and using different means to ensure we're still getting our most vulnerable vaccinated, and as I say, and that includes staff. And as I say, we recognise that we want to be able to ensure that we have some flexibility in that, because of course the other must do is that we mustn't waste any vaccine, and I think we've been very successful in that. But we recognise that it is hard yards. I think the low-hanging fruit of people coming forwards we've done, but we've got more to do. So I'm gonna I don't know, Mark, if you wanted to say any more, because Mark actually is the lead GP chair for the vaccination programme, and obviously I don't know if you want to say anything more before we go into questions, Mark.
I'm not especially, because that was very thorough. I thought.
Make sure I've said the right. Have I covered everything? Good. Okay.
I mean, I think a couple of things come to mind. One is about some of the numbers in terms of percentage of people vaccinated. Of course, the denominator for that is quite difficult at times, and we have populations, and you see that across London, inner London local authority areas, lower vaccination rates than some of the outer areas. But then there are reasons for that in terms of movement of population. We know that people, move quickly from one home to another, and it's difficult to always have contact details. You phone people up and the number's discontinued. We have in lots of communities, we have people who are currently living abroad. And if you add up all those different factors, it actually means that the numbers to get to 100% those factors are also very difficult. So then we come into all the issues that Jane talked about in terms of vaccine hesitancy and the concerns people have about that, and things, and various misinformation that needs to be addressed in a culturally sensitive way. And then I think Jane also mentioned about trying to think of increasingly different and more culturally sensitive ways of delivering the vaccine. So actually being able to move now, there's been a lot of movement in vaccinating the housebound, for example, in the last week to 10 days. That's really taken off, because permissions to move vaccines, there are quite a lot of rules and regulations which are stipulated centrally about how vaccines can be managed, etc. But also now we're freeing up more opportunities to run pop-up clinics. So Jane illustrated one in the mosque. The Haredi community initiative this Saturday evening runs between 8 p.m. and 12 p.m. or midnight. Although they're expecting to vaccinate beyond that, because they're full already, so people will, etc. But that's been running out of John Scott, one of the community hubs. So it's about using all sorts of different, whether it's about offering transport and taxis and things, but many people don't want to get into a cab because they're worrying about transmission. They don't want to get on a bus, same reason. Okay, so therefore we can run up a pop-up clinic near to where they live, whether it's in a town hall or church, wherever it might be. So I think being really kind of having a multi-pronged approach to communicating with people, engaging with people and dealing with their concerns, and also a multi-pronged approach to actually delivering that vaccine is the work that's going on everywhere. And actually that work involves community services, it involves primary care services, it involves voluntary sector, it involves mental health services, it involves local authorities. And I won't bore you with the different sort of governance arrangements people have to hold this and manage it. But I think it's an impressive kind of example of people coming together and working in integrative ways.
Thank you. Thank you both. Just before I open it to questions, can I just understand, I mean, is there the case, strategically, have you got sort of a vaccine hesitancy lead, as it were? I appreciate your overview of that board, but to just absolutely their sole job to focus on this and drive out different avenues.
Yeah, so Dr. Paul Galuli, who's the medical director of ELFT, is our lead. And we've also got, in fact, Jason Strelitz, who's the public health director himself, and also someone called Ellen Bloomer, who is a public health consultant, has been working on this.
Great. So thank you. I see 4 hands. So I think I saw Cllr Vaughan first. I'll take them in groups of 2 at the moment. I see 5 hands. Cllr Vaughan, Cllr Sweden, and I'll come for some more questions. Cllr Vaughan.
Thank you very much, Chair. There's a document attached to the agenda which is headed COVID-19 prevalence, and it's given a map of the area that you cover. Would anybody like to comment on that map and where COVID is affecting the region?
Okay, so before we go into that, Cllr Sweden, can I have your question as well, please?
Yeah, thanks very much, Chair. My question is well done, basically, and well done in the moves that are being taken to address vaccine hesitancy. And I'm not expecting you to have this oven ready by now, but over the last few days, the government has made it quite clear that those who are not lawfully living here should have access to the vaccine. So I wondered what steps you were taking to try and make sure that it can be rolled out to that demographic. Thank you very much.
I'll take those two to start with, please.
In relation to the map, in many respects, the thing we probably need to do is produce a number of these, because you'll see that there have been some significant changes in the number of the prevalence across North East London, with in fact the number of I think it's Burgundy getting a lot less. But what this does enable us to do, and this is pulled from public health data, is to be very specific about the ward areas where there are particular outbreaks. Or more prevalence, and so working with our public health colleagues, they have been really instrumental in targeting those particular quite small communities in terms of making sure information is available and obviously matching that to where we've got our vaccination centres and our primary care network. So it's a sort of it shows a bit of a map. In terms of Cllr Sweden's question, we've had a very long standing relationship with organisations such as Médecins du Monde, who I think have worked with us, or certainly me personally, over a number of years, ensuring that we have got ways of reaching into communities who perhaps who are less connected into services, and certainly we're working with all of our general practices in terms of making sure that people have access to vaccinations, and again using obviously the vaccination centres as a method and modality for that. And we've had very actively working with a number of our patient groups in that too.
Indeed, and there's lots of organised doctors of the world as well are helping us, various others.
Yeah,
and of course,
there's Médecins du Monde. I was just doing it in French.
and also in terms of the homeless communities, there's been agreement to actually escalate them in terms of the sort of in terms of cohorts, and clearly there are people there who are very disadvantaged, etc. But anyway, it's actually positively doing outreach work to connect with people. But of course, you don't need proof of address or passport or any of those things to register with a GP. So trying to encourage people to do that so they can get into the system. But I know people are often cautious because they're worried about these things. But we try and sort of promote all that, and there are obviously particular services which are geared up to doing the outreach work. And that includes offering the vaccination.
Well, thank you. I've got three further hands up. Fauna, can I take Cllr Chowdhury and Cllr Salva next, please? Cllr Chowdhury.
Thank you. Again, it's some appreciation for going to the community rather than inviting people to go to different areas. Previously, I had some issues with some of my constituents that the location is a major issue. One, if you're taking an elderly person, you have to go with the person, but then you cannot park your car to be able to be with them, and you cannot let them go on their own. So it is especially areas like Olympic Village or E20 areas. But I really appreciate that when someone is taking patient to places like Excel, they have parking facilities, lifts, and all the other things. So I when previously asked question about declining of taking the vaccine, also I was trying to understand, and if it is possible to give us some idea, if someone is declining, do they give you the reason why they don't want to have the vaccine? So is it possible that they have access issue, they have other issues, or they just simply don't want to have it? Because we need to make sure that everyone is safe, not a certain section of the community. If there are others who are at risk, then others are going to be at risk as well. Thank you.
And Cllr Salva?
Mine's following up, particularly from Cllr Sweden's, but one of the areas that I think is of real concern is those that aren't registered with GPs. And I know that there was a report out earlier this month on the impact of COVID on the lives of Latin American migrants, and they were suggesting 1 in 7 Latin Americans in London aren't registered with GPs. And so I just wondered where that work, that outreach work, is sitting at the moment, and whether or not there's a plan which we should be feeding into or have oversight, and whether or not as a council, you know, where does that joined up thinking happen? Because I think that cohort of those that are not registered with a GP are going to be so important as the vaccine rollout next stage happens.
Thank you. And can I just throw into that the obviously concern that people have about information being passed on to the Home Office and how you're tackling that challenge?
I don't know whether Mark wants to come in. I suppose just one thing just to quickly add, I suppose, just it's Councillor Chowdhury's point. We haven't, up until relatively recently, been able to sort of have that roaming or taking the vaccination out of specified areas because of again, it's a national registration of of it being a medicine and vaccination. And I'm sure you'll have heard on the press that, you know, initially the Pfizer had to be stored, or continues to still need to be stored up, you know, in minus 75 degrees. So some of the our initial approach to vaccination was very, very prescribed. But now that more vaccinations are coming and being made available, that gives us much more flexibility to be more agile. And I think we recognise that you know, that is really important. And in many respects, you know, that's going to be the thing that helps us with our you know, reaching, as I say, all of communities. I mean, I know we talked about our Black and minority ethnic groups, but actually also poverty plays a real big part in that as well. So it's about that. Just in terms of the decliners, I know Mark probably is best placed to respond to that. We are trying to gather as much information as we can about that. So we're working very closely with our Health Watch colleagues in gathering, using the community insights approach, and we're rolling that out across all of the boroughs. And again, utilising the telephone call centres at a borough level to also gather that, because I think, you know, so, you know, not people are going to have very different reasons for it, and some will be based on all kinds of stuff. You know, the fact that some people don't like needles, you know, that's quite a large. We haven't really talked about that. So when we get to a pill-based vaccination, that we'll all be happy about that. But actually, at the moment, it is, you know, that's a due consideration. So I don't know, Mark, if you wanted to add to that.
I will certainly, that in terms of trying to understand people's kind of reluctance, there is a lot of sort of outreach work and engagement with different groups, and Jane's just sort of touched on that. But there's an enormous amount of work going on in terms of trying to engage with community groups, and that's led by community champions much of the time, and trying to not only understand the reasons for hesitancy, but also trying to sort of talk through some misconceptions, preconceptions. And so, yeah, the reasons are a myriad. One of the good things about much of the primary care offer now is mediated through sending people a text message via the practice, because most people do have mobile phones. It actually works very well. And then you can press on that, and it gives you access to whether your local primary care hubs or your community pharmacists, etc. And people can then book up their appointment just by that, and they get a confirmation text saying when they're going to go. The practices can search on all those patients who haven't activated their appointment, and then you can ring them up, and you can have one-to-one conversations with them. And that's often led initially by sort of administrative staff within practices, but then passed on to clinicians to have in-depth calls, because people often want to speak to their doctor, etc., for example. So you do get a sense of why people are saying. We've had conversations where people say, I think I'm going to have it, and then a son or a daughter intervenes and say, no, you're not. I've vaccinated people who say, don't tell my children that I've had it, please. But I've come out without telling them. I've had conversations where we don't trust the government. Why would anyone be offering me and people like me a free vaccine? There must be something wrong with it. You know, so really entrenched kind of sense of prejudice, or being subject to prejudicial kind of policies throughout, you know, people's life. So it goes right away from that to just saying things like, well, you know, isn't it X, Y, or Z side effects? Didn't they make it with, pigs or this and that? Just plain misconceptions about things which aren't true. So I think that's, we can, and when it's something like that, you can often have a very sensible, easy conversation and say, no, it's not like that. It's like this. And some of the take-home messages are, no one's died of the vaccine. No one even gets that ill with the vaccine, but people die with COVID, as we know, in their tens of thousands, and so it's a mixture. And actually having a discussion on the phone does allow you to start to have a kind of consultation and actually explore these issues with somebody. But that takes time. And actually, that's why I think moving into other cohorts and vaccinating other groups, we absolutely mustn't lose sight on the numbers of people who haven't yet had it in those first cohorts. And that's really at the heart of the planning. We will not lose that. And those people will, bit by bit, I think, receive the vaccine. I mean, some people just say, I just don't want to go yet. I want to see how it goes with others. I'll get back to you. And that's quite often what you hear. And eventually, or sometimes you just hear, I'm not going to tell you. I don't want to tell you, and I don't want to ring you. I don't want you ringing me again. Okay, so it's a mixture of feedback.
Thanks, Mark. Can I, just in terms of Councillor Salva's point, in terms of sort of those that aren't accessed with a GP, and just drilling into this a minute, is the emphasis on then trying to get people registered with a GP so then they have access to the vaccine? Or is there a whole sort of emphasis to say, look, if you're in these current cohorts at the moment, you don't even need to be registered with a GP, come here and we will vaccinate you, essentially no questions asked, just to try and make it as accessible as possible? How are you dealing with that?
Well, at the moment we're confined to the vaccinating in those top four cohorts. So, I mean, you can go to the pharmacist, for example, but otherwise, if you're finding people, you would be trying to sort of direct them to get in, register the GP, because it's good for their health generally. It's not just about COVID. It's a good idea to get yourself into the health system. But otherwise, yes, I mean, people can now, they are now being advised. The government is, if you haven't had a vaccine and you're one of those people, you can now contact the NHS, and there are different ways of doing that. But the outreach work often will go, illustrated by the sort of the work that's being done to vaccinate people who are street homeless, for example. Sometimes the vaccine now increasingly is just going out in this pop-up model we've been talking about to actually do that. But that's now becoming easier. It wasn't as easy before.
Thank you. There is a sort of a national sort of campaign which again is about making sure people are aware of the fact that they can access the vaccine, which we are as a ICS signing up to. But I think Councillor Sweden made the point. Some of this guidance has only just come out, so we've got more work to do on that. And as I say, our sort of homeless outreach approach is is one way of testing that. But we need to do more of it, and it's definitely a takeaway from today as well.
Thank you. I've got 3 questions left in the remaining sort of 7 minutes for this item. So Councillor Snell, Councillor Spence, and then Councillor Hudson. So Councillor Snell first, please.
It's been an absolute life-affirming experience for me to be a volunteer on the vaccination programme across Hackney this last few weeks. The splendid lot of people I'm working with, and not least all of the vaccination volunteers, GPs and the like, who's finding time on top of their normal shifts to spend time. And what of course is weird, and one of the reasons you need that level of goodwill, is because initially, because we didn't get vaccine delivered as we were promised, and then suddenly we'd be told, oh, the army will come in tomorrow with 1 day's notice. But more recently, because people aren't taking up the slots that are there, so GPs are desperately phoning around trying to get those slots filled up. You need to be flexible, and for all of us, I'm sure medics and volunteers alike, it just seems a waste when you could be giving out a lot more vaccines in a day. So there's 2 questions. It seems to me that ultimately, if we trusted our local health practitioners, we would not be so rigid about the top 4 tiers. We would actually say, hey guys, we've got a load of spare places here. We've done everything we can to get out to the top 4 tiers. let's let it rip just to fill up the remaining places, with a particular focus on independent care workers, because that's what worries me. I mean, if we're getting such a poor uptake in care homes, I worry even more about the carers that I see coming in who work for 5 multiple clients and aren't very often eligible, don't see themselves as eligible for picking up this. So I think the first question is, you know, is there more flexibility? Is it being too rigidly run from the centre for us to make use of everything we've got there and to target the people who need it? The second thing is, if we're going to be more generous and widen it out more widely, then we have to have that absolute commitment to picking up the groups that aren't getting vaccinated at the moment. And in your report, Jane, I mean, you indicated, and I realise it's going to vary across the area, but you indicated that basically the Asian community was showing good rates of take-up. It was particularly black communities, and it was particularly women within those communities were scared. And I've seen people, as you say, coming in crying because they didn't like the idea of needles. I mean, you know, there's no question there's a lot of fear out there. When I talk to my black friends, their worry, particularly in the African communities, is all the science is coming out in English. There's a long history of misleading social media in other languages that goes back months and months and months, and we somehow have to challenge that and meet that. And I know some good stuff is going on in Hackney already from our comms team, but I just wondered what you're doing to target that group. So number one, are we allowed to open up more widely? Number two, but then what can we do more for those groups that simply aren't taking up the vaccine at the moment?
Shall I pick up the first one?
Mark, let me just go to Councillor Spence and then Councillor
okay.
first. Councillor Spence.
Thanks. Yeah, I'll keep my question brief. I wanted to know about what data we may have already about the attendance rates in different settings between, for example, the regional centres, local centres, pharmacists, GP practices, and what that may say about what we do going forward, and the questions that have been raised already about who do people trust.
Thank you. And Councillor Hudson.
Thank you. First of all, I very much agree with Councillor Stell's point regarding people who go, care workers who go to multiple homes, whether they be completely private people or whether they be council employees. My other question is when people say, you know, why should the government give this? It's free. Can you please tell them it's not free? It's being provided at great expense by the British taxpayers. They may or may not be a taxpayer, but it's absolutely not free, and make that point. And also, I understand it's the case with certainly with the AstraZeneca one, that by having it, you reduce the rate of you infecting somebody else if you have it. And so it's for the good of their family, everyone they meet, as well as themselves.
Thank you, Councillor Hudson. So, Mark?
Well, it's good that and the fact that AstraZeneca have now shown that with research in terms of reduced transmissibility. It's really good, really encouraging. We kind of thought this would be the case, but of course all the original trials were done on the basis of preventing serious illness and death. But it's great to see that that's now being shown to be the case with the follow-up trials that are continuing as we speak. I was just going to pick up about the moving down to the cohorts before technically permissions are given. One of the things you have to check is that across North East London, for example, there's enough vaccine in the system to do all the people who should be done in the first 4 cohorts. Because if you start moving too quickly into other cohorts, the vaccine supply that is just pushed from the centre, we don't ask for, can we have more here, more there? It's just done. So the modelling is all done at the centre. So if they start seeing, in terms of, we enter the data on the computers, they see who and the age of people receiving. If the large numbers of people are receiving it, they'll say, hang on, the vaccine is not being used correctly in this area. We should redirect the next supply to somewhere else, because they'll be using it on those top 4 cohorts. So we could only ever do things around the edges a bit. So always people, when they attended a vaccine centre with a carer, we'd invariably vaccinate the carer at the same time, because clearly it's in the best interests of the person that the people they live with are vaccinated similarly, and that those permissions are becoming freer and freer now. But so those numbers are always quite small. But we did literally around the time you were asking your questions, and where we couldn't fill in the number of appointments available in City and Hackney last week, we did get permission to move to the 68 and 69-year-olds in the next cohort, and encourage practices to invite those people of that age who would otherwise also be at high risk for having long-term conditions, etc. And that was done on the basis that the practice would have to show evidence that they'd done their best to contact people to get them in from those first 4 cohorts. So when practice says, yeah, this is what we're doing, we're really trying hard, we won't stop trying, but in the meantime, can we just get a few other people in? That's now, those permissions have been negotiated and approved. But of course, next cohorts will be opened up pretty soon anyway. The 15th, we're expecting that week after next, we will be, sorry, hang on, where's the date? No, next week, we will be opening up next cohort. So it was a sort of temporary situation, which we've sort of moved on from.
And Mark, just before I bring this item to a close, vaccine disinformation on social media. I mean, is there anything we can do in our footprint as an ICS footprint, or are we more reliant upon national resource to tackle it via social media for different groups? Or
I'll pick that up. We're really working to not rely on national media. You'll be pleased to know we're definitely. So Don Neem, who's our communications lead, has been working really closely and to say using the experience that we've got in not just City and Hackney but in other boroughs about the different methods that seem to work well, and I think also, particularly, as I said earlier, actually getting a range of people who are able to get some of these messages out through WhatsApp. I think WhatsApp is a very, it's not used by everybody, don't get me wrong, but it seems to be used by lots of people. So with videos and in different spoken languages and also different approaches. We've obviously also got to ensure that we're using sign language as well. And, that's been a very, a key focus, just using multiple media. But as always good to get feedback or ideas about other routes to do that. And then just to pick up Councillor Spencer's point about the sort of, I suppose, the attendance rates at the different different places where we're providing a vaccination. So primary care, I have to say, are top of the pops when it comes to their being able to get the levels of vaccination through. But as Councillor Snell said, sometimes the delivery supply chain doesn't always match that. I think certainly we've had it's been a bit slow, certainly at Westfield, again, because of some of the supply. So we've actually had to, and it goes back to the cohorts, as people said, as we predicted, really. I think those larger vaccination centres will come into their own as we go through the next cohorts. Cllr has been pretty busy because, again, we've been using it to vaccinate people like London Ambulance Services. But as I say, we're now in this quite complex planning piece of trying to match what we know from the intelligence we've got in relation to vaccine hesitance with then the rollout of the programs. And then, of course, the other thing I want to say is, of course, we've got to staff it as well in a way that also is flexible. And then the opportunity for us is then to keep hold of some of those staff to help us take not just from a health perspective but social care, because obviously pre-COVID, as you remember, we were having some real challenges that. So actually we've attracted a lot of people and interest coming into North East London who want to do their bit. So we're grabbing hold of that too.
And also to add the Collins, one of the refreshing things is that you get some innovative, somebody does a video having had their vaccine, takes photographs, puts on social media. We've had some wonderful videos in different languages from community champions, and well done, you, brilliant. Can we all use that? Of course you can. And people like that Don I can see on the call will help coordinate at the NEL level and say, right, everyone, these are great resources. And so that sort of mixture of working at the NEL level and local comms two-way has been really helpful. And really the local authorities and others have been at the heart of all that. But as Jane says, it's so much a work in progress. We always want to hear more ideas and better ways of doing it, and etc. And of course, one of the things about the mass vaccination sites to get there was the National decided to send letters and keep the invites to those groups in that way. And now we're moving towards trying to get invites to those mass vaccination sites more coordinated, aligned up with what we do with all our rest of our local offers. So again, lots of learning from how we do this stuff as we go along to improve our approach.
Thank you, Mark. Thank you, Jane. I mean, it sounds like a lot of work's going in, and we're very grateful for all the work you're doing locally, and particularly the efforts you're doing to make a local focus. So thank you very much indeed. Can I draw that item to a close, because we've slightly overrun on that item, and move on to item number 6, which is the North East London response to the consultation on the integrated care system. The actual consultation document we've put in the agenda pack for people to see. This was a consultation that came out just before Christmas, with a response just after Christmas on the 8th of January. I think NHS England were certainly very much pushing towards what was described as option 2, which is probably more of a top-down, if I summarise this fairly, system vis-a-vis the option 1 in the paper, which was a more sort of, struck me as being a more collaborative local approach. As I understand it, the response from INEL was to support option 2. So can we just have a very brief overview as to what was the thinking behind going for option 2, and what does this mean for us as the local footprint in terms of having 3 separate systems working under one umbrella, which is what we've been working towards? What does it mean for that going forward?
Thank you. So I'll start off before I hand over to Henry. So just to explain how we pulled our response together, that was actually quite an inclusive process, kicked off by a workshop with all our partners represented, health, local authorities, health watchers. So we had all those voices together, and then we shared the different drafts and got feedback, so we could fill that out. So it's actually a partner response, but Henry will pick up on the detail. But I think it's important to highlight we're expecting the next iteration to be published tomorrow, within which we believe there's going to be a different sort of slant to the option 2. So although we can discuss it, it probably is going to be overtaken by events. I think that what we have been asking for anyway in our responses is that there may be something at a board level, but actually how you run or govern each ICS actually should be permissive and allow those integrated care systems to develop that with each of their partners, rather than to have a top-down model and we all have to align to that. But I'll hand over to Henry, and he can provide some more detail because he's closer to that. Henry.
Can't hear you, Henry. For some reason. You're not muted. Maybe turn up your sound.
I think Henry's had some difficulty previously.
He's unmuted. We can see him speaking. No.
Oh well.
Right, okay.
I can. Shall I say a few words whilst he sorts himself out?
Yeah. Go on, Jane, if you would.
Well, because well, I suppose just to pick up that point that you made in relation to the I think the question is, will the legislation, the white paper, will the changes derail what we have been working towards over the last however many, my legacy, shall we say, how many years in North East London? The answer is no, because I think certainly, I think it's quite helpful from what I've seen of the white paper actually, and actually, really continuing to ensure that we've got the right approach to delivering that sort of borough or sort of place-based delivery of our integration with, obviously, then people working across North East London, as we've just described. The importance of improvement and I think Alwen also articulated, through COVID. To be honest, we could not have delivered the response, not just critical care, but in terms of community and mental health, by not working together across organisations. And I think one of the perhaps things that perhaps gets lost a little bit in translation with this is, this is what's very positive about these changes. It is a real shift away from competition, which I have to say, and don't tweet me too much, but I think it was detrimental often to healthcare and delivery of a joined up service, to one of collaboration. And the new white paper it really, I think, continues to help us in that. So, and I think certainly what Henry might have said is, in terms of option 1 and option 2, there wasn't, I think that there was very little between them. And I suppose what we wanted to avoid is too much ambiguity, because of course, part of the issue is, with change, you need some certainty about what it looks like. So I'm very confident that what we've got in place, and the way we've developed integrated care working in North East London, and as I say, with our boroughs and cross boroughs, is very much still the blueprint on which to move forward. And again, as I say, we've talked about that, the role that primary care networks play, as well as at that very, very local level, is all part of it. So I don't quite, the white paper will pop out tomorrow. We'll need to sort of go through it again, and then we'll need to come back with some analysis and perhaps an oversight, an overview of what we think it means, and then in many respects the timelines of this next phase going into 2022.
Thanks, Jane. Henry, we got you back? No, we still can't hear you. Oh well. All right. Look, I mean, thanks for that. I mean, Henry, it's a shame because you prepared to say something, and I'm sorry, but we're running out of time on this item, so I think I'm going to sort of knock it on the head in terms of trying to work out the mic situation. But we'll work you out for next time to make sure we can either get you a device or a way you can speak. Jane, just before we sort of close off on this item, I mean, some sort of meeting, just your view. I mean, is there a potential sort of clearly desire to integrate adult social care in the health system, but is there a risk, or some might see it as on the positive side, that adult social care gets taken away from local authorities and gets put more within the NHS? Is that something you foresee, or not?
No, I mean, yes, because there are some benefits to bringing that more closely, but I think certainly there would be some challenges as well. I think certainly, I think in North East London we've got some really good examples of where we've used the Section 75 approaches to have that integration, and you don't need statutory changes to do that. I think there's been some question about whether there's a chance to review the Section 75 vehicle, but certainly I think from our perspective we would want to maintain that, because I think we get into all kinds of different challenges by social care, so trying to change that model. So but I'd be lying if I've read all of that in what I've seen so far. I think that's the sort of thing we'll need to tease out once the white paper comes out, I think. Henry's saying next time he'll do some expressive mime if he's not able to get on.
Right. Okay. Well, thanks. I mean, Councilman Hudson sort of suggested if Henry, you had put anything in writing, feel free to circulate it to Jarlath.
I think we'll aim
to
do a summary of what our analysis is of the paper when it comes out. Yeah.
Fine. I see Councillor Snell raised. I'll take one question now, because then I just want to move on to keep this time. Councillor Snell, quickly, please.
I mean, my experience since I've been involved with this scrutiny area is that the best collaboration works bottom up, and hats off. We waited for the government to give us guidance on devolution, and in the end we just said sod it, and basically our adult social care, our local health partners just got on with it, and it's been of immense value to us. So what concerns me is there's a lot of emphasis on place without talking about the importance of local authorities. And I just wonder what we can do to ensure that that's kind of super important, particularly a place like Hackney that has now got so much joint commissioning in place. What we don't want is change that's going to upset all of that. And the other one, I guess, is that through that process, it does mean that, you know, in Hackney, me, Ben and Patrick are there to keep an eye on what's going on and be lobbied and pass on the concerns we hear from our wider community and all the other people on this committee. And so I just wondered if you could explain to us, do you know if the ongoing role of councillors is safe in either of these options, really? There's an extent to which I think we in Hackney think we might be safer under the thing we know rather than change where that's not specified in the future.
I mean, I don't know if you want me to answer that, Jane. From the information which you don't know until you've seen the white paper, is there's been quite a lot of pushback from every response I saw about being clearer and strengthening the role of local government. So I'm expecting that the new iteration will have something in there. But also as an ICS, we're really clear about the primacy of the local, which, you know, through our 80-20 rule, which, you know, most decisions take place closer to home, and that's therefore where we wish to see the emphasis in terms of decision making. And of course that means local authorities too. And that relationship with health and wellbeing boards, I think, is critically important.
Fine. Well, thank you very much. I mean, it's clear that we need to revisit this once more details are published. It may be that it's back on the agenda for an update at the next meeting. With that, I will draw this item to a close. Thank you. Sorry, Henry, you weren't able to contribute. Thank you very much, Jane and Mary, for your contribution. Item number 7, just briefly, obviously this is Jane's last meeting before taking up her place in Devon. Mary, can you just give an update on the process for Jane's replacement? Is it going to be seamless, or are we going to have a period of interim, perhaps with Henry in charge? What's the plan?
So yes, Henry is. So it was going to, where we planned it, he was going to do his glorious bit, and I was going to say, and Henry is going to now, you know, be the interim. We made a decision with Region that it was not the time now to go out to recruit for a post. We were in the middle of COVID, and people that would be eligible, which includes Henry himself, would be very busy and wouldn't be able to pay the attention they'd need to apply for a post. But also we knew that the white paper was coming up, and it's really hard to define a job description without knowing the context or the framework in which you'd operate. We want to have, so we believe that we'll kick off post-Easter. You know, just fingers crossed there's no other waves, and we maintain our sort of trajectory of coming out. And what we want to do, what we're designing, is a very inclusive process. So we'll be working with each partner to help shape the person specification against which we will appoint, and there'll be a range of stakeholder engagement sessions, as well as having quite a broad panel. So a very inclusive process from writing the JD to actually making the appointment. But Henry's going to be able to speak next time. We'll sort out his IT.
You'll let him speak. Well, thank you for that overview. Yes, I mean, we're very happy with the stability of Henry being appointed in terms of the interim, and congratulations, Henry, on that interim appointment. And we'll obviously watch this space. With that then, I'll bring the substantive items to a close. Thank you to all our guests and colleagues from the NHS. We're just going to go through the minutes and the work programme, so please don't feel you need to stay for any longer. Jane, again, thank you very much for your efforts and your time over the years. And thank you very much. And next meeting, we'll see you all. Thank you very much.
Thank you. Thank you.
Bye.
Bye.
So while our colleagues from the NHS go, I've got item 8 is minutes from the last meeting. Can I take those as agreed, please, members? I'm grateful. Thank you. There were two responses, one to Norma Dudley and one to Christopher Sills, and the responses are in the agenda pack. Another item's been raised with us, which we discussed in the pre-meet, which was a submission from Nelson, North East London, Save Our NHS, in terms of patient charging and the hostile environment. We've discussed this in the pre-meet, And what the suggestion will be that we will write to the government expressing our concerns in terms of the hostile environment and patient charging. Some members, understandably, take a neutral on this committee, take a neutral viewpoint, and so we can make it clear that it doesn't necessarily come from everybody, so as to maintain keep everyone on board within the committee. There's a suggestion as point 2 of that we write to our acute trusts and ask them to consider referring patient charging procedures to a new body, of which Mary Gabriels, who's just left the meeting, chairs. And I think my suggestion is, well, I think, you know, rather than sort of go around the houses on that, we can write to Mary Gabriel and that body, and if they have remit, ask them to take it into consideration, and they can or they can't, depending on whether they do have the remit to do so. And we will also copy in our letter to government to Dr. Habib Naqvi. Thank you.
Yeah.
So that's a plan of action in relation to that. The work programme, item number 9. It strikes just me just hearing there that obviously getting an update on where we are with the structure and the white paper is probably something that might be quite prudent to do so. And it may well be that another form of vaccination update, just in terms of where we are at that stage, in terms of particularly in terms of vaccine hesitancy, in terms of certain community groups, is also important to revisit. I'm keen just to try and keep this as relevant as possible. But can I suggest any other suggestions? Send them through to Jarlath, and then we can we can take them on board and try and fit it in. So with that, unless there's any other business which I haven't been notified of, the next meeting, as I understand it, is on the 14th of March. So next month, been brought forward to avoid purdah for the London election. With that, unless there's anything else, I'll close the meeting.
Well done, Chair.
Okay.
Yeah, good timing as well.